Sorry to take your time. I'm Dr. Romesh and surgical oncologist. 50 years back, when AIDS was acquired, nothing was required. Now, we all have a surgeon's experience of locally advanced gastric cancers being treated by us rather than EC, early gastric or very limited lesions, T1, T2 lesion like that. So having said that, once the gastric tumor has gone to the cirrhosis and got adherent to the gastric bed structures, including pancreas, and also where the lymph nodal metastases have been very significant, which we all decide by PET scans or even diagnostic lab and all that. I wonder whether most of us would become like me, retired heart surgeons, in the sense the overall survival, disease-free survival, following these radical gastrectomies with sophisticated, physiologically compatible reconstructions and extensive lymphadenectomy, what is it that we achieve at the end of the day? Probably the adjuvant therapies like CTRT might have helped us. It is a compliance rather than really, it is a complacence in the sense rather than real good outcome of it. And we as surgeons should understand the physiology that when gastric food is mixed with pepsin, mucin and acid presented to duodenum, duodenal digested food is presented to small bowel. So when the food which is not treated or acted upon by gastric physiological secretions, the intestine would not be able to take it, leading to various nutritional, including the reflux and all that adding to it. So probably the disease-free survival, quality of life has to be weighed very cautiously. And I would like to ask the radical young surgeons whether you would like to have a neoadjuvant CTRT before putting the knife on, or the adjuvant setup. Which one has given you better results?
Sir, excellently put forward, sir. I think as surgeons, of late with the advancements of various chemoradiotherapy techniques and then immunotherapy also, there is high chance that patients who are otherwise inoperable at front, they are still becoming operable. Personally, I have an experience in a 70-year lady, recently operated. Upfront there was possible liver and pancreatic infiltration, but she underwent chemotherapy and immunotherapy, and surprisingly the tumor has vanished. As Birappa sir was before addressing the same issue, we went ahead with a radical total gastrectomy, but we got a complete response. So still in this era of advanced adjuvant treatments, there is a role of such therapies, and the road is not closed for such patients.
Chemotherapy and radiotherapy, I feel that it's a very great level player. It makes average surgeons very good and very good surgeons average. I mean, the results wise, if you see. So maybe that would tell the scenario.
Definitely, any cancer multimodality treatment. That too, in gastric cancers, there is no other go. We should have a MDT in each and every case, and we should have a diagnostic laparoscopy in each and every case. In each and every case, better to have a lavage and cytology intraoperative. These are the new norms. There is no other way. Only surgeon is a hero. So definitely, chemoradiotherapy role is very, very high.
Good afternoon, sir. I have a question regarding the sentinel lymph node navigation surgery. Is the procedure for use of ICG standardized? The dilutions, the concentrations, and the method of injections?
Like I said, it is not it. Each have their own way of doing it. Some do it endoscopically on the table, so that the tumor is identified at the same time is marked. Some do it preoperatively a day before. So it is not a standard. That's the problem. We have to accept it as a standard of care. Only when it's standardized, we can accept it as a standard of care.
Sir, how is it injected laparoscopically? Is there any way to localize it to the submucosa?
That is endoscopically done. Usually done endoscopically, preoperatively a day before, ideally. Sometimes, I mean, Western surgeons, because they can't afford the endoscopy a day before, they are doing it on the table intraoperatively by a simple syringe. But most of the Eastern data, like Asian countries' data, is primarily endoscopically done preoperatively a day before through endoscope.
So what is the optimal time needed after injection of ICG to the detection of sentinel nodes?
So sentinel nodes, usually 20 to 25 minutes is good enough. But for delineation of arteries, we need it on table. So IV is injected for delineation of vessels. But for nodes, it's better to do day before so that we get all the nodes covered.
Sir, what is
Because
the
more so, we previously operated patients who have underwent chemotherapy, patients who have inflammations can clog the lymph nodes and lymphatics and can cause skip meds and clogging of vessels. So giving enough time can allow us to detect all the lymph nodes.
Sir, what about technetium-based radio?
So like I said, that requires a lot of equipment. Gamma probe is required and permissions to use that, and it's a difficult thing. We don't have experience, we've not seen that. So that's the reason the addition of near-infrared cameras into regular laparoscopy and the Firefly has made our job very easy, because all it requires is simple click of a button, you'll get an image of lymph node brightly illuminated by ICG. That's an advantage.
Sir, any studies based on single agent versus double agent or a combination of?
The data I put up in the advanced carcinoma, the study from China, it is done with simple ICG and NIR only. Whereas Senorita trial is dual tracer with radioactive collide and ICG, whereas Chinese study is exclusive ICG with NIR cameras.
Thank you, sir.
I would like to add one point there. In a scenario, intraoperative scenario, where you want to inject the ICG into the tumor or peritumoral area and see in real time the opacification of lymph nodes, it can be a useful tool, but the problem with that is there will be a lot of extravasation of the dye around the tumor. It will smudge the area and you will have real difficulty in identifying the lymph nodes also. So like Dr. Mallikarjun said, it's better to give the prior day instead of doing it on table, but it is again a need-based thing. If you want to see in a real-time scenario, you can do that.
Just to give it to that, Westerners are afraid of medical legal cases, so they're afraid of the anaphylactic reaction. So they prefer giving it on table so that if there are any anaphylactic reactions also, that can be taken up. So that is one approach of doing it. But even the manufacturer says it's only 1 in 10,000, so should not be worried about allergic reactions or anaphylactic reactions.